as her faculty. Dr. Radha is an anesthetist who has been working with NHS UK for many years, and she was also involved in management of chronic pain procedures in the UK. Last few years, she's been with us at Pallium, a few months in a year, volunteering with us in the home care and other educational activities at Pallium. And she used to be a teacher there also, especially in chronic pain management. And she has also worked in another cancer center in Tamil Nadu, Dadia Cancer Institute, with their palliative care department. Very welcome to you, Dr. Radha, and over to you for the session.
Thank you very much. Good evening to one and all. Thank you to Pallium too for giving me this opportunity. As Dr. Sridevi was mentioning, this being the first session on pain, you will be having few sessions. We will just see what is it that is different that everyone needs to know to move forward in your journey of palliative care. Oh, Gayatri, will you be able to share the presentation for me from your end?
Sure, ma'am.
Okay. First, as we'll see what is pain. So we'll start off with the basic important thing, that is definition, which everyone will be eagerly waiting for. The International Association for Study of Pain had introduced a standard definition in 1979, but recently in 2020, they had a team overviewing the whole definition, and the definition was slightly remodified. Next slide, please. So what are the main important things it states are? Pain is an unpleasant sensory and emotional experience, and few other important factors are which could be associated or resembling something associated with actual or potential tissue damage, and it is also expanded by the addition of 6 important keynotes. So the main features in this definition that you need to take from this are, it's an unpleasant. Is pain anytime a pleasant sensory symptom? Never. So it is an unpleasant sensory and emotional component also has to be kept in mind. And it could either be an actual or a potential. What does that word actual or potential mean? It could have a actual cut injury, or it could be injury of some other form also, not necessarily a physical cut injury. Okay, and then the important 6 factors were added in 2020. Why? Because this field as such is evolving. Why so much of evolving is happening is because of the recent advances. See, in the 1920s and all, this much about pain was not known. The fMRI, that is the functional MRI, availability and the expertise of fMRI is what has taken the importance of pain to this level, what is happening today. Okay, so these 6 important keynotes are very essential. So let's see what they are. Next slide, please. So these things have to be kept in mind. Pain is always a personal experience. That is why we normally say you should not belittle anyone. You have to accept what the person or the patient says. If they are in pain, they are in pain. You can't be judgmental in that perspective. So it is always a personal experience. So that has to be valued. And next is the difference between pain and nociception has to be understood clearly, which we will see through our presentation today. And life experiences do have a role. So for that, what it is, when the person is having the pain, at that point of time, what all is happening? So we saw in the definition itself, the emotional component. because again, the fMRIs have shown the differences in the structure and functioning of the brain in persons who are having these diseases. So any chronic diseases, for that chronic back pain is one of the things in which extensive studies have been done. So that also does have an important role in the further presentations. So expression of pains needs to be respected, as we said in the first one, because it is a personal experience. And next is pain usually was said to be an adaptive symptom. Yes, it could be an adaptive. For that, a common example is if someone comes to you with pain in the right iliac fossa, everyone, all of you will immediately go up and say that, oh, probable query appendicitis. So that is the clinching thing, which is known. But if it is going to be of some important symptomatic value, well and good. But it may have some adverse effects too when it is arising from some other region and it is not a important symptom, but it could be a disease per se by itself too. Okay, and last one, very important, not last but not the least, verbal expression is not the only way to express pain. Only if I shout or scream in pain will I get some treatment. Is that the way it has to be? Never, not at all. Okay, so for this, we do see patients in intensive care intubated, ventilated. So do we not treat their pain at all because they don't scream and shout? No. So that also all of you are aware. So if you could type in the chat box, if someone is in intensive care, how will you assess their pain? Is there no way to assess their pain? Just because it's just to we will go through assessment, everything in due course. But if you could just type in the chat, just to know how would you pick up or see some signs which you could relate to pain.
Either unmute yourself and respond, or you can type it in the chat.
You have all the monitors running, isn't it? So are there any responses? I couldn't see any.
Not yet, ma'am, not yet.
Okay, no worries. So see, when someone is in the, you will see their heart rate going up, blood pressure increasing, sweating, teary eyes. So there are many factors many signs which you can find. Okay, next slide, please. So these all have to be kept in mind. These 6 factors are very important and essential. Next, this is a pictorial representation. This all of you would have gone through in your physiology, but I'm just going to take you through in a simple way because this is what is the nutshell what all of us have to remember. So basically, any symptom, like we have receptors in different places. If it is skin, you have the touch, temperature, pressure. Then if it is joint, you have the stretch receptors. Organs different, you have the distension, which is expert. So depending on the site, you can have different type of receptors. But ultimately what happens from that peripheral receptor site, the information is taken through the nervous system. So along with that, some chemical mediators also can have a role and play a role. So that is how I'm represented from the periphery. So from the receptors, afferent carries the information. Then you have the spinal cord where crossover happens importantly. Then you have the ascending pathway. Then the brain, you have the amygdala, thalamus, main central center. Then you have the descending pathway, which is very important, equally important from our point of view. And then again, the efferent goes back. So this is the full arc or the circle. Why have I put this? Because knowing this is important. Because only if you know how the whole process is going on, the same thing is what we are going to use when we are going to use it for treatment point of view. So this is the basic pathway how the pain is conducted from one point of or source to perceive it. Next slide. So having this in mind, we will move forward. Next slide, please. So we will have a case in mind. A 38-year-old male who was diagnosed with CA with oral cavity. He is the breadwinner who is married with 2 children who are 9 and 2 years old. His wife, who is a housewife or a homemaker, he is at present unable to go to work as he's having his treatment, and he's also generally fatigued with the disease proper. His main concerns are school fees. How will I be able to pay the fees and send my children to school? How will my family survive? So keep this case in mind as we go through, and then we will see what are the things that we need to have, or we'll come back to the case afterwards. Next slide. So as I said, what is the difference? So why do we need to know? Because as I said, only by understanding it will be helpful. So what is nociception? Nociception is detection of noxious stimuli by the nociceptors, followed by transduction and transmission. So what is transduction? What is transmission? Why am I taking through all this is because understanding these things are the important factors. Transduction is like some energy which is converted from one form to the other. So we said the receptors are there. Then how will it reach how can it reach the complete whole arc? By, as we say, by physically the path is there. That is one, that is transmission. Transduction is how, as I said, some chemical mediators, how some signal could be picked up even by chemical, like you have the prostaglandins, cytokines, all those things. So if it's an inflammatory process, those are the mediators through which it will be conducted. So that is transduction. So how all the chemical reaction, the physical transmission through the nerves. So that information conveying from one receptor to the central nervous system and back to periphery, that is nociception. That is perception of what it is. Whereas pain as such, if you see, it is a product of higher brain center processing. So that is where the role of emotion also. So the actual unpleasant emotional and sensory experience generated from the nervous system, that is pain. Okay, so that is why we need to know the basic difference between these two. Next slide. So coming to the pathophysiology. So the mechanism by which this damaging impulse is perceived by the brain is not a simple, straightforward one. If it was, it was thought to be a simple one. Till the 1920s, what was thought as it's a fixed system, this is how it works, all those have changed to a very great extent. Because why? They have found that it is not a simple fixed hardwired system, but it exhibits something called as plasticity. We will see a little bit more about it also. So what does plasticity mean? We'll see. So the next thing is that, as I mentioned, it was considered to be helpful. It is a symptom which is going to help. So it could be helpful in that per se. But when pain becomes a maladaptive symptom, or it is not a helpful symptom, and it persists for a long time, then it is called as chronic pain, and that itself is a disease per se. Okay, so if it is not going to be having any protective function, when it becomes pathological, it is a disease on its own. That is why the importance is gate. Next slide. So what is neuroplasticity? It is the capacity of neurons and neural network in the brain to change their connections and behavior in response to new information. So basically, and then what happens because of this neuroplasticity or change or the ability of the nervous system, we'll see even it can form new connections, It can generate new, like ectopic, which all of us are aware. We know about ectopic in the heart. Some new center becomes the point of trigger. So like that, which, for example, in the nervous system, we have always seen, we have the sympathetic, parasympathetic, motor, sensory, all, they are all not far apart. They are all close together. So stimulation of one stimulates the other, or even one, some stimulation can generate new extra neural connections, or extra neural sites itself can be formed. So these all, we will see how these happen. So this is what, so it is not, if it is to happen in one path only, it is not following that. It can change the path, it can change the response. So those are the reasons why the complexity of pain itself has increased, and that results in damage or dysfunction. So this is the important, important take home to take, is this neuroplasticity. See, there are plus, like what to say, pros and cons. A simple example, I'll say, the pros or the benefit of neuroplasticity is, anyone is, you can learn or do something at any age. That is the difference. Maybe the efficiency may be less, but the ability. So that is one of the positive things. Similarly, the negative aspect, if you see, the emotional aspect, because they've seen, and which has shown, emotion, mood, and the experience does have a role at that time of injury, or along with the injury, or during the whole process. So that has an impact on the structure and function of the brain. So these are the main reasons which have helped us to study and do more. If we know what is the cause for it, then correction is also possible. So those are this neuroplasticity, or the important ability. What happens is the thing to understand and use it in practice itself. Next slide, please. So, and what are the modulations which can happen? Again, modulations happen in many parts. One such is peripheral sensitization, which I was telling so far, is explained a little bit. So, initial injury, the inflammatory mediator is released, the interleukins, prostaglandins, they can increase in quantity. Okay, and the whole thing, what happens, is called as the inflammatory soup, and this itself it increases, it gets exaggerated, and makes the pain response more. So this one such thing is called as peripheral sensitization. Okay, and so that these type of things happen both in the periphery and the central nervous system. So this peripheral sensitization is one such mechanism which is happening. Next slide. So similarly, central sensitization can also happen. What is central sensitization? It is an increase in the excitability of the dorsal horn, so that the dorsal horn cells have a lower threshold. Even for small stimulus, they do respond and cause the pain. And so they basically respond to low intensity stimuli that might not have been painful initially. So that is the central sensitization, one type of central sensitization which can happen. Next slide. Next comes neuropathic pain. What is it? It arises following diseases or injury to nerves from a number of etiologies. It need not be one. There are some more also which I will add on. Some are mentioned. Ischemia, trauma, infection, these are all very common. Diabetes mellitus is a disease which all of us know, peripheral neuropathy. Chemotherapy, radiotherapy, they are also said to cause neuropathic pain to a very great extent. So how the neuropathic pain etiologies also, these are causing, we will see in the mechanism also, we will see a little bit more. So these are things to be kept in mind. See, chemotherapy, radiotherapy, we see so many patients, okay? So suddenly, so why the importance I'm stressing, if you don't understand or know that this component is there, you will not even be able to think to treat about it. So only if we know that this cause is there, then we can go about managing it also. Next slide. So what are the mechanisms? So as I said, these are the common things which have been mentioned. Spontaneous ectopic discharge, as I said, which we were just telling before. Then there can be altered gene expression. Something called as Wallerian degeneration is said to happen. And that is one type of gene expression which causes or exaggerates the pain. And involvement of the sympathetic system, collateral sprouting. All these are few mechanisms which have been mentioned. And as I was telling, for all these, any one or all four can also happen. So these are the probable mechanisms which can cause peripheral mechanisms in generating or causing neuropathic pain. Next slide. And from central sensitization per se, these mechanisms involved are thought to result in, again, neuroplastic changes. And in that, two important things are generally mentioned. Next slide. They are wind up and central sensitization. The simple way to understand this is amplification. What is amplification? Generally, what does that word convey? What does that word mean? Can someone type? Simple English meaning.
Amplifies to multiply or
Very good. That's it. To increase.
as
Further
mentioned.
increase. That's it.
Another
That's it.
is
Thank you very much.
increasing
So
the
that's
intensity.
also
Increasing the intensity to further increase.
exactly. So that's also just increase in size, someone has said. That's it. So basically, it makes small big. So that is the basic underlying process. So it is called as either wind up or central sensitization. If it is short lived, it is wind up. If it persists for very many years, then it is called as central sensitization. So the basis is amplification. So the pain is amplified or increased. Okay. So the common example which is given is low back pain. Okay. Because one injury could have happened even for someone at the age of 20, 25, some fall. Okay. Fall, accident, or anything like that. But that primary injury can last till their age of 60, 80 also. Because because of that injury which gets amplified and stays with them for so many years, that is one of the mechanisms under central sensitization. Okay, so it is just amplification. If it is short-lived, it is called as wind up. If it is long-lasting, it is said as central. Why do you? Because when you pick up any book and read, you will see all these. Oh, what are these? Are they Greek and Latin? No. Once you are aware of it, it's not going to be difficult to understand and move forward. Next slide. See, as I was mentioning, in many theories and many advancements have come, of which in this gate control theory of Melzack was identified in 1965, and which is very, very important and useful one. A simple example is when a child has a small fall and cries, what do we do? Anyone wants to say how would you console the child? Very many ways are there.
We either distract the child or soothe the child and take his attention from the pain to elsewhere.
Yes, that is one. Anything else which you would do?
So we involve him in some activity so that the primary focus is shifted.
Okay. Other than that, you would normally do one more thing. What is that? You would generally rub the area, no?
Rub the.
So that is something which is done by many. That has some significance. What it is. See, normally pain is carried by small fiber, C fiber. Okay. If you see the picture on the left, so what happens? Normally pain is carried by the C fiber, and you have the large fiber, A beta fiber. So they are generally in that we saw the inhibitory pathway that is generally inhibited. Okay, so because the C fiber is activated, you see in this picture that projection neuron and outcome, the pain is perceived. Okay, by rubbing, what happens? Their large fibers are stimulated. So when the large fibers are stimulated, the inhibitory pathway is also stimulated. So see the picture on the right. So when the inhibitory pathway is stimulated, pain is not perceived. So the inhibitory pathway inhibits pain perception. Okay, so this is what was identified by that gate control theory by Malzac, and this is the basic principle how TENS machine works. So even this large fiber, this whatever we do know, rubbing the area, these type of other non-pharmacological mechanisms, some work in this method, and TENS is one of the important, simple, basic. It's a simple, easy, patient-friendly. You can use it for any number of small pulses. And there are very many types of machines available now, which pocket TENS, so many things are there. So this is the basic theory under which and how it acts. So this is something. So if you see in the second one, so you see the outcome of the pain is not perceived. This is the the mechanism by how it works. So it gives evidence also how it's not blindly accepted. Okay, so this is something which was identified and is of great use to patients also. So far, have you all, is it okay? Do you want me to take you through anything specifically? Anybody wants to say something or any clarification needed until now? Okay, if everything is okay so far, we'll just keep moving forward. Next slide, please. So this slide, basically, as we saw, on the left side, you've got all the pathway. On the right, you've got all the treatment. This is like applied. We have all known of applied pharmacology. Basically, applied is what? What is the physiology or pathophysiology, and at what all level you can use management options. So as mentioned by Dr. Sridevi, you're going to have few sessions on it, every aspect of it. So this is just an introduction. Okay, so where you're going to know what is pain, how are you going to assess it, those elements we will see. What is that all you need to know? And then the treatment options, I'm not going to go into it because I won't spoil the charm of the next session. You're all going to get enough information on every aspect of it. How can you manage and things like that. Okay, but this gives a pictorial representation of from the periphery to the central nervous system, and the whole PPT is going to be shared with you. And so these are the ways of management, how it is done, and there is clear evidence how each level you could use different agents, and same agent also can have many effect in multiple areas and things like that. Okay, next slide. So next we'll go on to what are the types of pain. Okay, so generally, broadly, we know something called as acute pain. At the time of injury, what happens? And then we have been telling about chronic pain, anything which lasts for long, more than it used to be called as 6 to 12 weeks and more than that. And now we have many more factors coming into that. Any pain related to conditions such as diabetes, mellitus, arthritis, tumor growth, as I said, radiotherapy, chemo, all this will fit into chronic pain. And next you have something called a somatic pain generated by nociceptors in deep tissues. And then you have visceral pain, which is from the organs within the human body, like you have the abdominal pain. So those are the coming from various viscera. Next slide. Neuropathic pain, which we saw due to damage, either physical or a potential damage to nerves, and which causes, we saw also the mechanisms. Now the next two things are pertaining to pain per se, and these two may be some terms which you might not have heard. Okay, one is allodynia. What is allodynia? It is pain resulting from a harmless stimulus. Normally, that stimulus would not cause pain. Okay, but because of all these neuroplasticity and all these things which we have heard in the last half an hour, this can happen. So a common example is touch. Normally, touch does not cause pain, but touch per se can result in pain. Or normally patients will come to you and say their own clothes. For example, if someone is having a pain around their knee, a dhoti or sari touching on their knee can cause pain. See, that is a very difficult situation, isn't it? For someone which normally does not cause pain. If that causes pain, it will be really bothering, fearful. So these things you will know only when you see patients. Normally, when you see chronic pain patients, they will. This is mainly the neuropathic pain, which is representing and picking up like that. So whoever is, so if someone complains of you pain on touch, it is very clear that it is allodynia and some neuropathic element is there, and appropriate management option for that has to be done. Okay, and next is hyperalgesia. What is hyperalgesia? It's an exaggerated response to normal stimulus. Normally, to some extent, say for example, the intensity, a small pinprick should cause pain of that intensity. Whereas if a small pinprick causes pain, exaggerating, or patient is in tears, so that is hyperalgesia. It is hyper is always exaggeration or increased. Okay, so these allodynia and hyperalgesia are the things which are happening because of the neural component in it. And referred pain, I think all of you are aware. Common examples what we give are myocardial infarction, pain in the left arm, and in today's world of all laparoscopic surgeries, when patients go home, we do say of not to be worried of if they have pain in the shoulder, because air or remain any remnant gas under the diaphragm could cause pain in the shoulder. So these are things which you need to be aware of. So these are the various types of pain, which all of us, any different types of patients will be coming to you with different types of pain. Okay, next slide, please.
Just to interrupt, Dr. Dilip, you have your hand raised. Do you have any questions?
Yeah, so wanted to just check in
Please go ahead.
allodynia and hyperalgesia.
Your voice is breaking.
Sir, we can't hear you. Your voice is breaking. We just heard allodynia and hyperalgesia. What was the question?
Is the pathophysiology same for both of them?
Yes. See, they are all neuropathic pain in different aspects. Both pathophysiology it could be one of the neuropathic pain. As I said, no, all of the four things which mentioned, depending on the area, if it is peripheral. So the pathophysiology is nearly the same.
Both
Is
are
that
a part of the recruitment, Dr. Dilip. the recruitment, when it happens at the central level and at the level of spinal cord, there is a chance, as madam told, there is a neuroplasticity. The adjacent lamina get also involved, so that you will get something which is not expected. So even when you touch the patient will experience more pain.
Okay, thanks.
No worries. Better to clarify if you have any. Thank you, Sri Devi. Okay, next is, how do patients describe and how are you going to ask when someone comes to you with a complaint of pain? So these are the standard things which we are aware of. Where is the pain, how much it is, for how long it is, where all it is going, any specific factors that increase or aggravate it, and anything that makes it better. And last thing, what impact has it got on daily activities of the person? Important is mood and sleep. Those two things have to be kept in mind and asked specifically. Okay, for this we do have some mnemonic also. The next slide, please. Normally it is said as PQRST. So all what we saw in the previous slide only are going to be there also. What provokes the pain? What is the quality of pain? Does the pain radiate somewhere? And what is the severity of the pain? And what is the timing of pain? So the same thing in different ways. So this mnemonic is commonly used. So to keep in mind, so the main thing, why are we doing all this? So that we don't miss anything. Okay, next slide. Why do we need to assess pain at all? Okay, for that question, there are many things. If we don't assess, how will we manage? That is one. Okay, and then even if you're assessing to manage, your quality of management can be understood or assessed again with the, if you have a methodical assessment pattern. So, and that is one of the reasons why we need to do. And not only for patient assessment management outcome, in the long run, always research and things. No, today we are able to know more and improve is because of regular assessment. So it is from research and future perspective also. Proper assessment is very essential and will be helpful for having many evidence-based results for clinical trials, research methodologies, and everything like that. So assessment has to be understood and done properly from many perspectives. Next slide. So you have separate assessment for acute pain and chronic pain. We will see what are the things that are available. But here I will tell you, by number and names, you can have plenty. All of you have to use what is best for your area or your institution. These things, no, we will give you information, but you have to tailor make. That is what you have to use, what will work for your patient. See, some places you may have people who may not be able to read and write. So then you have to use something which is simple and easy for them to, because ultimately what, everything, patient is our main, we are doing everything in patient's best interest, so that my patient gets the best and gets better, and end of the day gets the benefit out of the treatment. So you have to get all the information and use, or even you can make something from these which will work for you. Okay, so the normal ones which I used are the numerical rating scale, visual analog scale, and there's something called as dynamic pain assessment also, because you need to know when the pain is there. For example, if someone is sitting all the time not having any pain, is the assessment complete? They may not even tell. They'll tell, only when I get up and walk, I'm having pain. So that is also important. And so why another important thing, you need a baseline in assessment, so that to, as I said, to know your quality of outcome or the outcome measure. How was it to start off? How is it now? How is it progressing? Is it getting better? Is it getting worse? Yes, it can get worse also at times. And then you have to see, then go back to square one and do assessment again and then move forward. Okay. And similarly for chronic pain, we have separate questionnaires, because whenever chronic pain component you're taking, it can have, as we have seen, it can have multiple causes. And so there are specific assessment tools for the disease per se. Say, for example, dementia, diabetes. Now you have to have assessment of those diseases also. And in general itself, each component of the pain is again graded as mild, moderate, severe, like sleep, depression, everything. Those additional scales are also added on to that. So that also you have to keep in mind. And as we have been seeing about neuropathic pain, that also go. There are some scales which will have 30, 40 parameters in that, because each parameter will be again graded to mild, moderate, severe. So that, like that, we have separate scales for acute pain and chronic pain. Next slide. So we'll see next few slides of how they are. So the number normally 0 to 10 is what is generally used. And in that itself, you can have, see, everyone may not be able to understand 0 to 10. If they understand, nowadays most patients are able to understand. So either that, or if they say mild, moderate, severe, you can appropriately put a number to that. And these are all and 0 is no pain and 10 is the maximum or worst pain, like that. So this is one way. Next slide. You have the facial one Backer scale or the facial representation. Next slide. This is a body chart, what is said. No, this is something simple. You can give this. This one can be used in many places. You can give this to the patient and ask them to mark where are the places. And in this, you can use different colors. Like, say, for example, a different intensity of pain can be marked with different color. Next is first assessment, you can use one color, and second and third assessment, you can use different color. That will show the your outcome or the benefit of management. So all these can be kept in mind, and this is something simple and easy. You give this to the patient, anyone, even someone who is not educated or anything, they can just put, or this gives freedom for them to represent without any inhibition. So this is some basic thing which is being used in many centers. You have one for the front, one for the back, so that they can express comfortably. Next slide. As I said, the chronic pain tools are these are the ones which are commonly used, in which quality of life is also a component of it. So that is also assessed. Okay, next slide. So cancer pain. So what is the difference between other pain and cancer pain? Cancer pain, we will see, this is from 1986, WHO has been striving hard to alleviate and manage, but still complete success in that part is not achieved. Still, they say only some 4-6, max is 2 to 4%, something only they could attain. Why? Main thing is non-availability of analgesic drugs at the point where the patient needs. Now, next stage is that now the drug, maybe even morphine, if that is the gold standard that's available, but it's not available at the place where the patient needs it. See, globally, this is the condition, and many rural areas, where you have a lot of patients with demand, the supply is not reaching there. So this is an international problem, which is being faced by all parts of the world, and that is where all of us need to work to get it. And maybe see, these type of training and things are happening mainly to break that barrier and make that available to where it is needed. And from cancer pain, next slide please. From cancer pain assessment point of view, not only there are additional factors which you have to keep in mind. See, for example, pain and breathlessness the first and last symptom are said to be 80% of patients, 60 to 80% of patients may come with that. Okay, but the ones in between, pain itself affecting their activity, causing anxiety, depression, that can all be related to one and the other. And other things, nausea, and loss of appetite, losing general well-being, they are all very, very important things from the patient point of view. So having in mind all these and trying to manage the symptom appropriately is equally important. If one is not corrected, still they may not have benefit of relief. So this is one of, it is called as the MD Anderson pain inventory, and this has to be kept in mind, and you have to look into all the factors and see how much of correction can be done. Like symptom management is very important, and doing that only will be helpful. So as I said, other specific forms are there for each disease per se also, which could be used if required. Next slide. Now, if you could all think of the case which I was mentioning, okay? Because why I brought that case back to here is that now we have seen so far that pain is not only a physical, so you have to know something called as managing total pain. What it is, these are the 4 components. There could be physical component, there could be psychological factors, social factors, and spiritual factors. So now, with that case in mind, a 38-year-old patient having oral CA, who has a family, who is the breadwinner, and his queries and worries we were having, he was wanting, he is unable to go to work, he can't pay fees, how will his family survive? So it is just not his pain and suffering from the disease. Is that the only problem that he's having? No. So if you see all those things, the physical pain is the physical component. Okay. And the psychological pain is, see, he is already, he's in fear and he is suffering and he's anxious, he's depressed because he can't go to work. I said he's fatigued because of the treatment and disease per se. He is also having treatment. So with all that, he's unable to do anything. So that amount of psychological element is there. The social and financial. So as I said, how will the family survive? So that component is also there. And spiritual component can always be there. Why am I suffering? I led a very good life, still why? Or I did something bad when I was young. So that is why I'm getting punished now. So all these can be there, hopeless feeling. So so if you don't deal with each one of them, your treatment will not be complete. So from that point of view, if you see, you have to do a multidisciplinary assessment and a multimodal management. So you have to put in your assessment plan of these factors also and then deal with them accordingly. So as I said, it is a team effort. Only then, for example, many times, if you don't deal with what is that is bothering him the most, you have to ask. So as we have already seen, is pain as such is a personal experience. For this person whom I'm telling, for him, his children may be the most important. So even if you give him treatment or anything, you may not find a good response. Only if you spend some time and talk to him and find out what is his issue. See, all this in being the initial phase of your course, you will be having sessions on communication, everything as such, to become a master in managing total pain. So, but now I'm just throwing some seeds for a thought so that you all have to start thinking in this way and then move about. So that the main thing is multidisciplinary approach has to be done in assessment, and multimodal management has to be done so that the total pain relief can be obtained. So that is what to be kept in mind. Okay. I think with this, we will come to the end of the presentation. And anyone has any doubts or anything, please unmute and ask, or type in the chat, and then we'll move forward. Okay, thank you very, very much for patient listening.
Thank you, ma'am, for touching upon the basics of pain, covering the total pain aspects also. We'll wait for questions from the participants.
You can come out of the presentation, Gayatri.
You can either unmute or you can type it in the chat. I'll read it out. Has any of you seen patients with central sensitization? Reporting to you with head to toe pain, whole body pain, which may not be related to what you are expecting. Anyone? Or allodynia?
Is anyone already working in palliative care or chronic pain, anything like that, in this whole group? Or
Yes,
do they
ma'am.
have anything?
They started
Ah,
working.
just started. Okay.
Actually, for bedridden patients and all, yes, their bystanders, caregivers used to say that while changing the clothes and all, they'll be crying. Maybe patient will be semi-conscious and all. So is that allowed?
I currently work in children's palliative care, and I recently had a patient that had past history of gangrene, but in his lower leg. And now I feel he presents with hyperalgesia because I could relate to the word. This child, because I work with children, he will not let you touch the leg, because even if you touch the leg or if water falls on his legs, he starts screaming with pain. So this is my experience with hyperalgesia that I have had personally. But previously, I think this child had gangrene.
Doctor, thank you for sharing that. But I think while touching, that is with non-painful stimulus, right? The touching and pouring water is a non-painful stimulus. Then
Correct.
the child is crying of pain is more like allodynia.
Oh, it's more of allodynia.
Yeah.
Okay.
So
Fine.
that is might be due to the, as you said, he has a history of gangrene. So that is due to the unaddressed pain from the past. So all this nerve recruitment has happened, and that is
Correct.
why that altered sensation, and it is very, very difficult for the patient, because even when you switch on the fan a little fast, they'll
Correct.
start experiencing pain.
To air. Yes. Thank you.
And some situations where the patients who are paraplegic, where they can't sense anything, but they will sense pain.
Okay.
So that's very and how do you manage this patient, just out of interest?
As of now, we are trying to get a follow up with the orthopedician, because it originally started with that, to see if it is anything related to nerve or something like that, and then from that. As of now, actively, I'm not managing his pain. He's supposed to go to the orthopedician for the referral immediately, because I recently got the new referral.
Okay. So maybe next session we'll be covering a little bit on neuropathic pain management also. And I am almost sure that the orthopedicians are not going to address this neuropathic pain. That's what we have been seeing for decades now. So if you get a chance to see the patient again after the pain management session, next session we'll be covering adjuvant. So probably I am sure you will be able to help him a little bit. And that with the least expensive medications, you can actually change someone's life. So, Dr. Dilip?
Yeah. So, Dr. Dilip here. So, I wanted to check. We all know that pain is very subjective. and wanted to understand because I do sometimes see such patients in oncology. So how to evaluate and or some things we can evaluate or distinguish between pseudo pain. For example, sometimes some patients come and report they are hyperalgesic, and we touch them and they will say, okay, it's very painful, very painful. And then when we start discussion and ask in detail certain things, and unknowingly if we touch them, then that time they will not report painful. So very difficult to understand whether it was a true pain or it was pseudo pain or it's more psychological.
Do you like to start?
See, and from as we said, no, initially you can't say or take it as pseudo pain because you have to believe patient's words and then go ahead and then see the response. See, many times, no, that's where then you put your common sense also. So sometimes when they are seeing or when they are distracted, what it is, you go through, but straight away don't be judgmental and say no, but you that is where your assessment might will be helpful. So you just have to start off believing them and see how it goes, and then during the process of your further management sessions and things, you try to pick up whether it is true or not, and then move from there. Straight away telling that it is not a pain of big concern, no, they will lose faith and trust in you. So based on that, and also their disease per se, what is there, no? And then based on that, you move about with the further management. And then you can also see sometimes even you can use placebo and see if that and all. Again, you have to know the patient very well, and management also should be started first. And you to a certain extent you can see what is the intensity, then go. And as we were telling, no, you will have further sessions in assessing the pain, and then this assessment is what is going to help you in when you go to the management option. So as I said, no, I have not really touched anything on management because you have management sessions completely. So you have direct medications, adjuvant medications, and then depending on the intensity is what you're going to do. So use all those methods and then see the management, and also use your skill to find out uh, by seeing patients few times only. One sitting you may not be able to do that, and one sitting telling them it's not pain or something will not be right from patient's perspective also.
Yeah, I fully agree with you. And the basic fact, because they're oncology patient and we are all aware that they may get point, only sometimes it may be patient attention seeking or something, but we all know they are disease patient. So sometimes, so we do prima facie take it as what they're reporting is painful, but eventually then we also put into counseling and psychological see and then try to reduce things. So that there are, I fully agree, there are multiple aspects in such patient, and we should go at least by what patient says first.
And psychological assessment, no, see that is why I brought up this total pain. Okay, the psychological element maybe, see, I'm giving some examples because, see, for example, it may be someone who is just by themselves. Okay, they're not having anyone, so the fear may be there.
Yeah,
Okay, so that fear may be overtaking everything else.
yeah,
So
yes, I
there,
agree.
a psychological assessment and giving some reassurance, nothing big. See, we know very well. See, for example, I'm just telling, the patient was having severe pain, you said, and it was the psychology. So one psychological assessment or your reassurance, don't worry, you come back to us. We have seen all this. Just telling them that you come back, no, maybe because they're not having anyone, nobody is seeing or talking to them, that itself will bring their pain down. So psychological factor and all, that is why again and again total pain concept is important to be kept in mind, and overall management will help.
Yeah, thank you.
Especially in your
Most
setting, Dr. Dilip, they might be seeing other patients with pain, or they might have heard stories of cancer patients having pain. So all this will play a major role in how they present also. And the hardest part for anyone in pain management, it is not about learning medications, but it is the fact that you have to believe the patient. That is the hardest part, being not judgmental. Like in chronic pain, patients' face may not be showing any kind of pain. They will not be screaming. They'll be having their normal life, but will tell you that when you ask for the pain score, they will tell you, I have 10 out of 10 pain. Then we say, oh, this patient is lying because he's not even showing any expression in his face, but telling 10 out of 10 pain. So not being judgmental is the hardest part than learning any pharmacology in the coming sessions. That is one thing. And as you rightly said, Dr. Dilip, sometimes no, they feel relieved when you talk to them, right? It is like Madam said an example of kid running and falling. Someone told you distract. When you talk to them nicely, sometimes they feel relief. So this your brain plays a major role there. Like you might have seen in religious rituals where people pierce and do some rituals for their religious thing. They are not crying, right? They are just smiling and doing all this. Can we imagine doing such things on us? And if it is a surgery, then you can't do it without anesthesia, right? So your
Yeah,
brain plays a major role in controlling or feeling what you're feeling as pain. So when you're doing it for a religious thing or you really want to do it, you will not feel the pain. But when the same procedure is done by a doctor for an intervention, that feels quite different. So it is important to understand why they are telling pain, even if you think that there is no pain. Again, that is from our point. It is we are just judging them. So sometimes they just need your attention. They just need few words from you as a doctor. Like every that just I've seen patients getting pain relief by touching and sitting near them. You sit near them and give us touch and talk to them for a while. They feel so much of relief than you give any other medication. So I think it's a combination of so many things, and we are very, very uh, like when I started, I was very prone to say, "Oh my God, this is a fake pain," because it doesn't look like in pain. That was the sentence that we very commonly use. So just
yeah,
adding my thoughts. Thank you for
yeah. I
sharing
agree.
that
And
question.
in fact, I give one other example when I was involved in one of the clinical trial in the institute, and when I saw a patient, and it was obvious looking at the clinical patient, we assume that he should be already in the pain. He should have pain, but patient was saying, no, no, I don't have any pain. So that was earlier really worrying us. And then after counseling, and then we asked him, are you sure that you're not getting any pain? And then he said कि साहब इतना बड़ा बीमारी है तो थोड़ा बहुत पेन होगा ही. And if I say it is pain, so I'm afraid that I will be out of the trial. So the psychology and human angle we have to take into consideration most of the time.
Thank you for sharing. I think we'll move on to the case presentation and then we'll
Yes,
continue the discussion after that.
exactly.
Over to you, doctor.
Good afternoon, ma'am.
So Nath, you can start reading the case presentation.
Uh, Actually, ma'am, I came across a patient 3 to 4 months back. His age was 32, male, unmarried male, was diagnosed with a mandibular symphysis, parasymphysis fractures with dislocation. Present complaint was complaints of pain over entire mandible since 5 days. Then complaints of swelling on entire anterior area of mandible. Complaints of difficulty in chewing food, and had history of facial asymmetry and history of fever. Then history of illness. The patient had history of an road accident. He was admitted to a primary healthcare center where the first aids were given and referred for oral and dental consultation. History of pain on mandible. He had history of pain on mandible for 5 days. He had mandibular parasymphysis fracture with dislocation. Due to this, he had to keep his mouth open, unable to chew food, was on totally liquid diet. He was had disturbed sleeping pattern and decreased oral intake. On examination, blood pressure was 125 by 80 mmHg. Temperature was 99 degree Fahrenheit, pulse 85 beats per minute. In local examinations, we have found unilateral parasympathetic fracture with dislocation. He had lower facial swelling, tenderness, gingival bleeding, and malocclusion. Treatment and investigations done. Routine investigations were done. That includes hemoglobin was 11 gram. Random blood sugar was 115 milligram per dl. Bleeding time was 3 minutes. Clotting time 6 minutes. And a panoramic radiograph was taken. And treatment was done and given oral antibiotics, analgesics, and advice for surgical treatment. Psychological aspects. 32-year-old man who was living with his wife and 2 children in a village. He was a daily wager in a tea stall, and that was the only income source of the family. He was taking medicines regularly for 5 days, but did not get much relief from pain. He did not miss his work for a single day, as he could not miss his daily wages. He was referred to have a consultation for dental surgeon, but was not willing for that initially. After 5 days, he came to the clinic for oral checkup and consultation as the condition worsened. He did not agree for surgical treatment due to his financial condition and wanted to get treatment with medications only. The medications were given initially diclofenac sodium 25 mg injection intramuscular every 6 to 8 hours for 1 to 2 days. Then oral aceclofenac 100 mg with ceratopeptidase 15 mg with paracetamol 325 mg or paracetamol 650 mg 2 times daily after food for 4 to 5 days or as and when needed. With oral amoxicillin 500 mg plus potassium clavulanic 125 mg 2 times daily after food for 7 days. Pantoprazole 40 mg 1 time daily before breakfast for 7 days. 5% topical povidone iodine ointment was advised 2 times daily for 10 to 15 days. Along with ORS 2 teaspoon 2 times daily for 7 days was advised. Main concern was pain, swelling, malocclusion, facial asymmetry, financial problems. Summary is 32-year-old married man with mandibular parasympathesis fracture with dislocation, pain, swelling, and asymmetry. Discussions points: how we can assess total pain in this patient, how the patient is dealing with his work daily with pain, what can be done for the patient to relieve it from pain.
Thank you. I will ask for inputs from the other patient. Thank you for bringing up this, and I'm glad that you explored the other areas like the family, where he's coming from, what job he's working, and unless we talk, we don't know why he doesn't want the surgery, right? Usually, what happens, we offer some treatment, patient says no, and then we say, okay, then you have to go through it. So I think you have explored why he did not want surgery and why he's going for work, etc. So I'll ask the participants, what do you think about this? Like, how can, I mean, he has to go through, I'm sure others will also go through similar situations where you know that the definitive treatment for this pain is maybe surgery or radiation or some kind of therapy, but the patients are not willing for it due to the uh, problems in the daily living. So, what do you think should be we should explore more, or how do we go ahead with this patient? Again, I think this is a very classical example of the total pain that madam was also telling, or now we were just discussing, right? It is not just about the pain over the chin, but it is also about pain affecting his daily work. So thereby he can't support the family. He cannot take leave also. So how this all this is contributing to his total pain. So I'd like to hear some comments from the participants in this situation. How will you generally manage?
Maybe speak to him regarding the surgeries, counseling.
Thank you, Dr. Shilpa. But I think the main concern is that how will he miss the work and probably the surgery can cost something, right? So that might be the primary concern.
Here, government hospitals do it for free.
Very good. That's what I was waiting for. You have to direct him to somewhere where it can be done free. So, see, one more thing is, his total pain could be the reason he himself can't have the treatment. No, the psychosocial, psychological, psychosocial. Him not being able to fund for his own surgery is the most difficult situation for anyone to face. So that how much of impact is going to have? I cannot fund for my surgery. See, as doctors would have said, and we all know that corrective that for especially for this particular case, managing surgical correction is what. Otherwise, he will end up with, as we saw the case also, one of the important reasons for chronic pain is improper management at the point or at the time when this happens. So, very, very important that he will be physically, mentally all upset. So, directing him to the right place where he can have the surgery is a very, very much. Thank you, doctor, for coming up with that. That is something that is also our duty to direct him to a place where he can get, if private is the option where he has landed up and he cannot afford to guide him to the right place where he can get the surgery.
Ma'am, excuse me.
Go
Yes,
ahead.
please go ahead.
Ma'am, actually, he was totally disagree with to go with surgery at that time. We have advised a lot of times, but I don't know what he has done.
I think from what I think is that even if it is a government hospital, you are mentioning that he's from a village, right?
Yeah.
So when you have to undergo surgery in a government hospital, you need to have a bystander with you. So he will definitely need to take one of his family members, either wife or brother or someone from there.
Yeah.
And it is not like an OP procedure. So they'll have to get admitted. They'll have multiple visits for pre-anesthetic checkup and everything. So traveling from the village to hospital is not being covered. And running a tea stall will not cover all these expenses.
No.
And someone coming with him, you will have to manage his food and stay over there. The surgery is for free, but what happens with the investigations and some medications while discharge? So this is what patients generally, whenever we offer admission, this is something which they are bothered. Like, we don't have money to come to you. I mean, once they reach here, the treatment is for free. I mean, most of the treatment, but again, you will have expenses like suppose he is accompanied by his brother or wife, that person's daily wage or activities are being compromised, right? So no one will be willing to come from a village. They may have to find a place to stay. There are so many places where they give free accommodation for procedures, but there are a lot of hidden expenses in terms of transport, food, and someone to run around for investigation. So that's a pain. People deny treatment even when it is given for free. It is because of this reason. There are a lot of charges that is coming along with, and being away from the tea stall for a week probably for the surgery, minimum a week, I'm assuming,
Yes,
with
ma'am.
all the workup and the discharge. And to start the oral feeds, it will take a few days. So maybe if he is away from the tea stall, there is no one to feed his children probably.
Yes.
Right? So we have to explore till then. Like why? We understand that you have financial issues. What if it is a government hospital? Then he may tell why he cannot do it. So yeah, just sharing my thoughts.
Totally true, Sridevi. These add-ons or think out of the box. See now, even government hospitals asking for bystander. Either you provide bystander or they're telling you have to pay 700,000 rupees per day or 1,000 rupees for 12 hours bystander. So all which you might not think, as you said, no, because the government option, we have to look at all these things also. That is why this is an empathetic approach. No, we don't know. We from medical point of view, you may be thinking, oh, treatment. So he is getting treatment. So these are all. That is why this total pain is so important. Again and again, we'll be like a parrot. We'll be coming back to it again and again. Yes, it has significance, and that is something. That is something all have to start thinking in that perspective. See, as Sridevi put it, like what to say, very crystal clear. So these things which you will not think of, we have to start thinking. It is just not the treatment alone. The bystanders, the patient may not eat, okay, cannot eat, okay, but the bystander cannot starve, no. So, but only other things are, see, that doesn't mean there are no way out for all these things. As Dr. Sridevi mentions, that there are many places where they are giving to, for example, accommodation may be given free. Because there are additional, see, in most of the oncology centers, many places many will be aware. Many oncology units next to them, they have places where they will be giving for very low cost or sometimes free accommodation, then the food and things you will have. So because everything has to be kept in mind. So you have to ponder into why are they telling? What are the reasons? How can they be managed? So that is the important thing. So looking into an all-round picture, then slowly pondering. See, and all these things, no, if you straight away bluntly ask him, he may not tell. That is where psychology assessment. You either you have a psychologist or something, you can speak psychologist or social worker. Simple, basic is you need a social worker who will be able to help the patient and help the physician to find out, be a link, and which can be helpful from the patient point of view. Only then total care provision, even looking into total care. So, see, only if we go into the various aspects, then management can be thought of itself. So, that is something you have to keep in mind. If you have and multiple, you have to spend some time.
Another
Whether
point
it is
you have
possible
asked
within.
is about what can be done for the patient's pain relief. So you will be covering the management of pain aspect later, but I think for this kind of patient, the definitive surgery is one way to manage the pain, right? You can't have a displaced fracture, and this is a joint which moves,
Yes.
the most commonly moved joint in the head and neck area. So we cannot say don't move. You cannot immobilize that area without a surgery. So I think explaining in simple terms, now it is about losing maybe 5 days of work in that T stall. But if it is not treated properly, how it works, like what happens if the infection comes? In a very simple term, maybe sometimes drawing pictures of this area, showing some pictures in the computer, telling that this is where the problem has occurred. If we don't fix it, this is how it's going to be like. So then you will be losing your, if there is an infection and a lot of complications which happen, then you will be losing the job for a month probably. You may not be able to support your family at all. So this is a chance to correct it. Maybe we can fix it in 5 days and inquire about what are the barriers. Like these may be the barriers, like food. When you go for surgery, doctors will write all sorts of protein supplements and stuff. They can't buy it, right? So explore all those concerns. You can't manage everything, but you may have a friend who will know us place where they give free stay for people undergoing surgery. Just connect to them. This, we don't need to go out of anything. You can always have those kind of conversations, but explain maybe this for this patient, pain relief can come from a better disease modifying treatment or a surgery. So maybe the explain in a way that they understand, not threatening. If you don't do it now, this is going to be much bigger later, but show them the picture of the bone. How is it now after the fracture? Why you have pain while swallowing? Why there is a malocclusion? So show them and explain. And then if we fix it, this is going to be like this. But if we don't fix it, it is going to be. So these pictorial representation always work with patients because they can't picturize how your mandible look like, right? How it functions. So it is very important to show them by pictures that this is how, in writing, drawing your own pictures and tell them how it works. That sometimes help. And maybe to talk to his family members if he's not coming alone, sit with them and okay, this is what we want to do. How can we support you do this together? So maybe maybe if he's coming, for example, if he's coming with a brother, the brother will say, oh, I didn't know that this has to be done. Let's do it. We'll do something. 5 days, we will support your family. Someone will step up. So that kind of meeting will also help. Someone who can take decision.
Yes.
Maybe you might have done all this, but I'm just adding for the sake of discussion also. Sometimes the patient think that I am now if I go for the treatment, it is going to be a problem for my family because I can't take care of them. But when you get some family members talk to you, they say, no, it is okay. We will take care of things. You don't worry about us. You go for the treatment. That happens very commonly. So exploring that with the family is also very helpful. Any other
Exactly.
questions?
So,
Yeah.
the main thing is that telling the pros and cons. Okay, because it is always, see, they are taking an option which is convenient for them. So, and he doesn't want to burden and things like that. So, but you have to tell them the pros and cons. What happens if you have treatment? What happens if you don't have treatment? So, you have to go into big detail, as Dr. Sridevi mentioned, but put it in simple terms and get back from them whether they have understood. Whether if he has understood that if he doesn't have the surgery, what happens? So, one is pain relief itself will not be complete. Functionality, what all it is going to affect. His health itself will go off if he can't eat at all solids. So all these he might not have thought. He might have just thought of overcoming that situation or that point of time. So going through the pros and cons and then looking at something outside, as she said, so a little bit out of the box, and only thing you need to spend some time. So either you do it or you get the help of a social worker to assess and do things and help you in the management, because end of the day you want the patient to get the best. That is basically our duty. Anything else? Something you were about to say, Sridevi? I think when I started.
No, I was asking if there are any other comments before we close the session.
Yes, if anybody wants to say anything, or maybe you can come out of this presentation and then any doubts in today's or. And one thing I just wanted to add on is, see, only when you all see patients, no more. See, this is basic knowledge you have, and as so many participants were mentioning about seeing patients, now with having or coming to know all this, and when you see more patients, more light this will throw and you will pick up more. So more patients you see, that is how your skill will develop, improve, and you'll be able to pick up things easily, and then you'll be able to join the dots. Oh, this is what it is. Oh, this is why this patient is coming up with these symptoms. So all these, one help the other.
Thank you, ma'am. There are no questions in the chat. Maybe we can wind up.
Yes, exactly. We can come out and.
Thank you, Dr. Radha ma'am and Dr. Sridevi ma'am, for the wonderful session. I hope you all find this much informative and enriching. Thank you all participants for your cooperation and time. Thank you all. Let's see again on the next session. Thank you.
Thank you very much. Thank you, one and all. Good luck to everyone.
Thank you.